Thank you for joining us. My name is Audrey Hassan, Patient Liaison for the Mds Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank the supporters for this webinar program: Acceleron, Bristol Myers Squibb, Gamida Cell, Jazz Novartis, and Takeda. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Sandra Kurtin, a graduate from the University of Arizona with a Bachelor of Science in Nursing with high distinction, a Master of Science in Oncology Nursing, postgraduate certification in both geriatric and adult practice, and a PhD in nursing. Her research focus is on health technology engagement, communicative health literacy, and health self-management among older adult cancer survivors. She is currently employed as a hematology-oncology nurse practitioner at the University of Arizona Cancer Center and serves as an assistant professor of clinical medicine and adjunct clinical assistant professor of nursing at the University of Arizona. Dr. Curtin is a member of the American Society of Hematology, American Society of Clinical Oncology, American Academy of Nurse Practitioners, Oncology Nursing Society, and Nightingale Honor Society. She has presented numerous regional, national, and international lectures on oncology, chemotherapy administration, symptom management, and clinical research. She's an associate editor for the Journal of the Advanced Practitioner in Oncology and is an editorial board member for the Oncology Nurse and the ASCO People Living with Cancer website. She is a member of the Board of Directors and co-chair of the International Nurse Leadership Board for the Mds Foundation and is a delegate of the International Myeloma Foundation Nurse Leadership Board. She has published numerous articles in peer-reviewed journals, including the New England Journal of Medicine, Cancer Nursing, Clinical Leukemia, Blood, Leukemia Research, the Clinical Journal of Oncology Nursing, and the Journal of the Advanced Practitioner in Oncology. With that said, it is my pleasure to introduce Sandra Kurtin.
Welcome, everybody. I'm Sandy Curtin. I am a nurse practitioner at the University of Arizona Cancer Center in Tucson, Arizona. I am a member of the Board of Directors for the Mds Foundation and of the International Nursing Leadership Board. And I'm very pleased today to talk to you about becoming a partner in your care. And we're going to work through the building blocks of hope, which you should receive as a part of your participation in this meeting. So we're glad you're here to learn more about living with MDS. So our focus is going to be on how do you stay well and what are the things that you can do to have the best experience possible. And largely that's educating yourself to empower you. And the first step is being here today in this meeting, because the more you understand this disease, the better you can manage your health and the better you can advocate for yourself. So we're going to talk about a number of things. One of the key strategies is to know your score and understand your diagnosis. And these two items drive how we select therapies, treatment options, and always consider a clinical trial as a part of those options. And you should have heard a little bit more from some of the other presenters about some of the very exciting clinical trials that are currently in process. Take advantage of resources and technology. So you're here today. This is great. There are other items, many opportunities for learning and tools to help you manage your health that are available on the Mds Foundation website. Stay well. We're going to talk a lot about that today. Staying well, otherwise well, not just managing your MDS, but your overall health is really critical to quality of life and your ability to continue with treatment and tolerate that treatment better. This requires that you communicate regularly with your healthcare team. I always tell my patients, I can't help you if you don't tell me what you're experiencing. I need to understand your experience so I can use my knowledge and skills to help you better manage your concerns. So let's talk first about understanding your MDS. Now, you may have already heard some information from other presenters, but you want to know what is your IPSS score and your MDS subtype. And there are a number of tools within the Building Blocks of Hope and on the MDS website that can help you understand this. The International Prognostic Scoring System, which has been revised from its original version, so thus IPSS-R, helps categorize MDS into one of 5 risk groups. We have very low, low, intermediate, high, and very high. And these risk groups are directly correlated or associated with the aggressiveness of the disease and the risk of leukemic transformation. We can calculate that score using an application that can be downloaded to a smartphone or be used online. And many of us clinically have these on our phones so that we can do this in real time as we're seeing our patients in the clinic. This is a screenshot of all of the resources available to you on the MDS Foundation website, and there are many. There are great videos, there are booklets that you can order for delivery, including the Building Blocks of Hope, and other items that you can view online or on your smartphone or tablet. So take advantage of that, visit the website, explore these resources. They can really be a great foundation for learning and managing your own health, which will help you living with MDS. This is one example of the You and MDS video series, and we have Dr. Stephen Neimer, who is the chairman of our board of directors, and really discussing firsthand experiences from patients about living with MDS. There is the Mds Manager Mobile App, which you can download in the various Google Play Store or either Apple or Android device. And it has features that will help you track some of your information, including symptoms, medication reminders. You can also use all or just a few of the features on this app to help you manage your disease. There's also now an Mds Foundation app. So this takes you directly from your phone to the Mds Foundation website, so you can access these resources readily, regardless of where you are. And this includes connections to our MDS Centers of Excellence. It'll give you the schedule for upcoming patient forums and events similar to this. And you, again, can access this on the Google Play Store and in iTunes. Participating in a clinical trial is also always recommended. We only have the drugs available currently today because patients took part in clinical trials. That's necessary to generate new therapies. So this is something that we always talk to our patients about when we're thinking about what the best option might be for you at any point along your journey with MDS, so that we can take advantage of these available therapies that might not otherwise be an option for you before they are FDA approved. So again, ask questions, ask, am I a candidate for a clinical trial? And what might be available to me either here where I am locally, or is there an option to be referred to a center of excellence where they may have a broader availability to clinical trials? Now let's talk about what you can do to really stay well. Being eligible for a clinical trial requires that you are relatively well. So the first thing that we want to talk about is avoiding infections. And certainly we've had a wild year with COVID-19 and the pandemic. But outside of that, and we'll talk a little bit about COVID-19, I don't have it on the slide here, but we'll talk about that. We want to monitor our blood counts. We know that MDS is associated with a number of cytopenias, low blood counts, and that can include white blood cells, which are necessary to fight infection. And we're going to keep track of that. We're going to avoid people who are obviously ill, wash your hands regularly, and talk with your healthcare team about symptoms that you need to report immediately so that they can be addressed before they become more severe. We do recommend that you be immunized. So get a flu shot every year. There are different types of flu shots. There are some that are intended for immunocompromised patients. So you want to make sure that you talk with either your primary care provider or wherever you're going to get your flu shot to let them know that you're in that category. Some of that is based on age as well. You should also get your pneumonia vaccine. And again, there are different types of pneumonia vaccines, and it will matter as to whether you have had a prior pneumonia vaccine or not. So just ask. We follow the CDC guidelines for anybody that is immunocompromised or over the age of 65, which many of our MDS patients fit into those categories. You should only receive attenuated shingle vaccine, so not the live virus. So there is one version that is a live virus, the Zostavax, and there is another one, Shingrix now, which is an attenuated shingles vaccine, which is the only one that we suggest you consider. Again, discuss this with your primary care provider or your MDS or oncologist that is managing your disease. Now, as far as the CDC guidelines for COVID vaccines, they recommend that everybody be immunized. There are some exceptions for people undergoing a stem cell transplant in that very early part of therapy immediately after the transplant. So again, we recommend that you discuss this with your physician or your healthcare team that is managing your MDS. This is an example of tracking your neutrophils. So neutropenia or low neutrophils, these are those white blood cells we talked about that help you fight infection. You can find these on your regular blood counts. So ask about getting copies of your blood counts. There's a total white blood cell count. Here, that number is the range is 4.0 to 11, so 4,000 to 11,000. And then there are different types of these granulocytes, or types of white blood cells. And we're going to focus on neutrophils specifically. And you can calculate an absolute neutrophil count by multiplying the white count by the percentage of neutrophils. Most laboratory reports will give you an absolute neutrophil count, and they'll either spell that out or they use this abbreviation of ANC. When we look at red blood cells, when those are low, we talk about anemia. So too few red blood cells is very common in MDS. Roughly 90% of patients with MDS over the course of their disease will develop anemia, and many to the point where they require transfusions to address that. These red blood cells carry oxygen, and when we have low red blood cells or anemia, we have fatigue, shortness of breath, sometimes headaches, or a rapid heart rate. The ranges for normal hemoglobin vary by gender, so male versus female, those ranges are different. And we look at primarily hemoglobin. Hematocrit is subject to hydration status, so we tend to follow hemoglobin levels in our patients. The last and most common blood cytopenia or low count is thrombocytopenia. So platelets are what help you clot your blood. And when those are low, you have thrombocytopenia. This can make you prone to bruising or bleeding. And in some cases, this can be severe if that number is quite low. The normal platelet count range is 150,000 to 400,000. If it's very low, so below 50,000 and certainly below 20,000, the risk of bleeding goes up substantially, particularly if you're on other medications that might affect platelets, including blood thinners or antiplatelet drugs that you might be taking for problems with your heart. So what can you do to stay healthy? Really, we want you to enjoy living, do the things that you enjoy. So ask for help when you need it. You might look at your lifestyle and say, what kind of modifications might I need to make? Learn to manage and report your symptoms, because again, we can't help you if we don't know about it. So learn to talk about the things you're experiencing and report those to your healthcare team. I encourage people to make a list before they come to the visit, and so you don't forget to bring it up when you see your healthcare providers. And then be an active participant in building hope. So being hopeful means feeling well as you can, and having the hope that you can manage your MDS effectively through treatment and other strategies. So what can you do about a healthy lifestyle? Well, you want to do the things to help lessen the side effects of treatment, and we're going to talk to you about what those are. You can also find this information in the Building Blocks of Hope, which talks about the most commonly available therapies for MDS. You can keep your immune system strong by having an adequate hydration and a good balanced diet. You can improve your emotional outlook throughout the diagnosis and treatment by gathering information, empowering yourself, and engaging your healthcare team and other members of your community to support you through this process. You want to manage your other health problems. So we really want to engage those other healthcare providers that you're seeing. If you have a cardiologist or a rheumatologist or one of the other ologists, as I call it, we want to co-manage and make sure that all of the illnesses that you might be dealing with are adequately or optimally managed. Fitness is very critical, and it doesn't mean you have to go out and run a marathon, but just simple things, walking and strength training, can really be critical to wellness. And again, you have to have adequate wellness to be eligible for a clinical trial. So exercise is the single most important way to combat fatigue as well. You can ask about a referral to a physical therapist. Strength training, I really encourage people to use these elastic bands. You can do it in a chair or you can do it standing, but just those simple strength training exercises can make a big difference in stamina and general strength. Light cardio, so just walking, brisk walking, can do wonders. So again, you don't need to go to a big gym and have a very involved regimen, but just simple things that we can all do in our own homes even can make a big difference. Get enough rest. So talk about this with your team if you're having trouble sleeping. Eat light before you go to bed, so don't have a heavy meal right before you go to bed. One of the drawbacks of all the electronics that we're using today, particularly during this COVID pandemic, is that blue light, that backlit device, makes it very difficult to go to sleep. It reprograms your brain to be active. So try to avoid taking your iPad or your phone and looking at that before you go to bed at night. Get a dark, quiet, and comfortable room for sleeping, and then help your body relax. Some people use meditation. Some people have music or sound machines to just help sort of bring down that activity in the brain before going to bed. We talked about nutrition briefly. You want to stay hydrated. Being dehydrated will make many things worse. Balanced diet, there's no magic diet. We want to avoid things that are not good for us. Highly processed foods, sugary foods, high-fat foods, and excessive preservatives. But there is no magic diet. Adequate calories and protein, so we want to find a balance there. Limit or exclude alcohol intake. Avoid fad diets. We don't encourage people to go to any extreme. We really need a balance of nutrition here. You should always ask about supplements. Is there any risk of interfering with your treatment? There are some drug-drug interactions that need to be accounted for. There's also some drug-food interactions. And so ask about any restrictions for other drugs or foods. And if you are adding any new drug in from another healthcare provider, make sure you talk to your healthcare team about that. Avoiding the risk of bleeding then. We talked about the normal platelet counts, and that risk of bleeding becoming more of an issue if you're below 50,000. So talk to your healthcare team about what things you need to do or watch for, and when you need to call for any kind of an emergent intervention. We're going to track your counts very carefully if you start treatment, and generally we do that even once a week for the first 8 weeks of treatment, because we know this is where those side effects of low counts might be more pronounced. Avoid aspirin or aspirin-containing medications if you have a low platelet count. Now, there are some people who are needing to take that primarily for heart issues. So again, this is where we need to be able to collaborate with your cardiologist and have a conversation about balancing your heart health with your risk of bleeding. And this goes along with those blood thinners that I mentioned or antiplatelet drugs, which are listed here. We want to avoid injuries or falls. So this is really important. If you are a little bit weaker, make sure you have help, and you might want to even get one of those emergency notification devices that you wear so that you can get help readily. There are quick tips available to talk about each of these items that we just discussed, and much broader scope of managing various symptoms, what you can do, what your healthcare providers might do, and when you need to call and talk to someone. You can access this through the Mds Foundation webpage, through the Mds Manager, and in the Building Blocks of Hope. Managing comorbidities, I think I've talked about this quite a bit. I think it's really great for patients to bring with them. Some people have those plastic card holders, and they have all of their care providers readily available so that we can communicate as a team and exchange our notes, and everybody's aware of any changes in your health, any changes in your treatment, so that we all do a better job of managing your health collectively. So having that contact information is really important to aid in that communication across the team. And then be your own advocate. So ask questions. I, again, talk to people about preparing for each visit. Have honest, open discussions with your healthcare team. Let us know what your wishes are. We can tell you what we know about you, but only what we know about you if you tell us about you. We know a lot about the characteristics of your disease based on laboratory testing, bone marrow samples, and such. But we need to know what your wishes, your goals of care are, and then we can better support those goals. Make the most out of every visit. Ask yourself, what do I want to get out of this next visit? Write down the top 3 things you want to discuss, and then really say, I have 3 things I need to talk to you about today, so that you would get your questions addressed in that way. We all know that sometimes you get to your appointment and you totally forget to ask a question, and you're like, darn, I wish I would have asked that question. So write it down, bring the list with you, and then talk to your healthcare provider, whoever's seeing you in that visit, to say, I have 3 things I'd like to discuss. It always helps to bring a member of your personal support team. This can be a spouse, a friend, other caregivers, or advocates, to help you remember to ask your questions and also to take notes so that you remember the answers that you get. Bring any information to share with your team, changes in prescriptions, any new over-the-counter medications, vitamins, herbal medicines. You can also talk about your symptoms, and tracking these over time is important. So if there's several weeks between your visits, you're going to want to keep log of that. You can do this through the symptom tracker, other strategies for note taking. And if you have seen one of your other care providers recently and have copies of any information, bring those with you, or at least talk to us about them, and we will have our team request those results so they can be included in your medical record. Any transfusions that you received will be really important for us to know. And then make sure you understand the plan when you leave. What is the follow-up plan? When am I coming back? What are my appointments? Are there any new medications that I've received? And did I get instructions for how to take those? Am I having referrals to any other providers? Are there any new do's or don'ts? And then again, reviewing who to call, where to go, and how to manage, your symptoms through the office. There are many resources, again, in the Mds Foundation website, but one of the greatest things we have is an advocacy program, and many of you have probably already met Audrey Hassan, who is our Mds Foundation patient liaison, and she does a great job of connecting you to those resources and helping you find resources that are close to home through the Mds Centers of Excellence and support groups. So reach out to Audrey. You can do that through the phone or via email, and or by calling the Mds Foundation directly. Thank you for attending this session. I hope you've learned some useful information that you can apply toward your journey with MDS. And we would appreciate it if you would complete our electronic survey. It's listed here for you. There are also paper surveys that are available upon request. So again, thank you for joining us. We wish you well on your journey with MDS.
Thank you for your wonderful presentation, Sandy. And thank you all for joining us today. As you know, our MDS support groups around the country and globally have had to cancel their in-person support groups due to COVID. So in light of this support group is for you to discuss any number of issues you're experiencing. If you'd like to ask a question, please tap the raise hand feature in the bottom menu bar, and then I will call on you. If you'd like to pop on your camera, or if you are more comfortable, you can start submitting your questions in the chat box, also found in the menu bar. And to limit background noise, please keep your microphone muted until you're asking a question, unless you are speaking. Once you start talking, it can sometimes be hard to stop. So keep this in mind because time limits are important to allow for others to join in. I see Bernard has entered a question in our chat function. So let's start with Bernard. He wants to know why the emphasis on knowing your IPSS score is so important.
Sure. So welcome, everybody. I'm Sandy Curtin. And so the IPSS score, it really drives our decision-making as treating providers. And so we account for the characteristics of your MDS specifically. And we know that there are some characteristics that are favorable and others that are less favorable. And they, based on that score, it will, again, as I mentioned in the presentation, it will assign you to a group of low, very low, low, intermediate, high, and very high. The differences there are in a very high risk MDS, for example, we need to get treatment started very, very quickly because that group represents a higher risk of moving toward acute leukemia. In a very low risk MDS, we may not need to do anything right away. So it's going to help us understand, I like to call it the tempo, how your disease might behave over time. And that, again, that risk of leukemic transformation. There are also criteria for drug approvals in various countries that are tied to certain subtypes or risk groups of disease. And so in the United States, for instance, where I am, there are approvals that specifically speak to individual risk categories. So there's a number of reasons that we want to know your score, and it's helpful for you to know your score so you understand those same concepts, obviously not at that same level of science. Hopefully that answered your question.
Thank you, Sandy. Great answer. I'm looking to see if anyone else has a question. Please raise your hand at the bottom of the menu bar. Oh, I see Madeline has a question. Madeline, you'll have to unmute.
Can you point me in the direction for how, where we find the steps for calculating that score?
Sure. So I would do a couple of things. You can go to the MDS Foundation website, and if you look on the bar, let me see if I can actually show you. Nope, we can't share our screen, sorry. You can go to the MDS Foundation website, and if you look under, you can either in a search bar put IPSSR, but also under the general resource tab, you will find it there. And oh, it says I'm enabled now. How exciting. Okay, let me see if I can just show you real quickly.
And Sandy, I can jump in. If you go to www.mds-foundation.org, right on the home page, you'll see a large banner that will say, know your subtype, know your score. And it also has information about knowing your subtype. So it can be found on our homepage.
Oh, I did it wrong, sorry. So this is how the MDS Foundation website looks. Can you all see that?
No.
No? Are you not seeing my screen?
I think I
You
need
can
to.
see it.
You can see it. Okay.
Yes.
And so, sorry.
There it
go
is,
ahead.
Sandy. Yeah,
Yeah.
questions answered. If you go back here on the arrow, on the large banner here, if you go back one, you'll come to it. Just click on the left arrow on the banner. Keep clicking. Keep clicking. There it is. Oh, no.
It's on the banner, but you can also find it. Here is the IPSS calculator. And what it's going to ask you to do is give certain information. And so it'll help you basically show the categories. It just takes a minute here of your hemoglobin, your neutrophil count, your platelets, your bone marrow blasts, your cytogenetic category. You're going to have to ask your healthcare providers, where do you have favorable cytogenetics or not? So you may not need to calculate this yourself, but you should ask about it and say, what is my IPSSR score? And which group am I in? Very low, low, intermediate, high, or very high. So that then will help you understand, sort of the risk, where you are in that spectrum or continuum of MDS. So hopefully that's helpful.
Thank you, Sandy. I have a question. Oh, it was in the chat, but now it disappeared. So if anyone else has a question, please let me know. Raise your hand. Oh, hi, Karen. Oh, Karen, you're not unmuted. Please unmute.
Okay.
There you go.
Is a rash an ordinary thing with an MDS person?
That's a big question. So there are some rare skin abnormalities that have been found in people with MDS because of the abnormal immune function. Fairly rare. Like certain MDS patients may be more prone to getting psoriasis or eczema, and similar in other immune suppression type diseases. But there are some rashes associated with some of the treatments. So there are, lenalidomide, for instance, which is one of the oral medications, can be associated with a rash. That's actually fairly common. You're raising your hand, Karen. Did you want to elaborate?
Yes. Prior to being diagnosed with MDS in January of 2020, my husband presented with really unusual rash, both subcutaneously, like like black arms or purple, like blood under the skin, plus an all over torso rash on top of the skin, etc. It subsided after. Well, he went to the dermatologist for biopsy the same day he had his bone marrow test at the oncologist. The results of the dermatologist biopsy was inconclusive. So his other doctors began removing medication to see if that helped. Yeah. Actually, the rash subsided and he underwent Vidasa treatment, chemo, and was in a sort of remission. But recently his rash has come back.
Not nearly as bad.
And he's done the dermatology biopsies again, which come back either drug related, but they range from lesions to subcutaneous, big leathery like situations.
Yeah. So there are certain subtypes of MDS that have a different cell type involved, and so the bruising and sometimes petechiae, which are little red dots that look like a rash, come from low platelets or platelets that don't work very well, and that's not uncommon in MDS. So easy bruising, petechiae, it's like somebody took a little red ballpoint pen and just put dots, are signs of potentially low platelets. Those little skin lesions that you are describing, there are, again, certain subtypes of MDS where you can get these unusual skin lesions. That's a fairly rare subtype, but it does occur. And so if the disease is not as well controlled, that may come back as a manifestation of that, where what you're describing is that the Vidasa worked for a while and then it was working less effectively. That might be an indication of that disease activity.
Okay, thank you.
Yeah, sure.
Thank you. The next question, I see a hand raised for David Cotter. If you would unmute. I see that David has also submitted his question in the chat box. When should you do an IPSS score? How often should you do the scoring? Does score vary depending on treatment cycle?
Sure. So the IPSSR tool is really indicated at the initial diagnosis. There are some other systems that are, the WPSS and others where, you're looking at things over time. There are certain centers that have generated scores that are more relevant over time. So there is some variability there. But understanding where you start is really critical. I always say that it's a continuum, and so we have very low risk over here, and we have leukemia over here. And where you are on that continuum when you start helps us understand, again, what's the risk of getting over here to leukemia versus not. And then at each point of, if we're worried that your disease is not as well controlled, we want to reevaluate it, because you can acquire abnormal chromosomes or abnormal molecular attributes over time. So the disease you start with is not the disease that you have, down here. And so it's necessary for us to repeat the bone marrow biopsy, retest those chromosomes and molecular attributes. Some of those molecular attributes are what I call actionable targets. So you may not have them when you start, but if you have, progression of your disease, you might have acquired these abnormalities where we have drugs that specifically target those. We may not recalculate your IPSS score per se, but we're going to evaluate all the components that we would in the IPSS system to understand how your disease is behaving at each point that we analyze it. Hopefully that answers your question.
I have a second question.
Sure.
Second question is, I've had 37 cycles of Vidasa.
Yeah.
And a bone marrow biopsy because my counts began to drop, whereas previously they were going down.
No, I'm on now.
They were going
Sorry.
very. Okay. Should I start over?
No, go ahead.
So my counts began to drop. So I had a bone marrow biopsy, and it turned out that rather than having 19% blasts, I was down to 5% blasts. And so the doctor decided to cut my Vidasa in half.
Right.
And I was not informed at the time as to what that possibly meant.
So that is actually, so it's a great question. And so when we see changes, as we're treating patients and monitoring patients over time, and we see changes in your blood counts, the question we're going to ask is it a treatment effect or is it the disease changing? And the only way to really answer that question is to repeat the bone marrow biopsy. And in your case, it sounds like it was a treatment effect. And so you can have improvement in your counts over time, but you can also develop treatment-related cytopenias, those low blood counts. And then we have to back off on the dose a little bit or schedule to, find that happy medium of controlling your disease without causing very low blood counts. Without knowing, the chromosome status or the molecular status of the disease, it's hard to know the rest of that answer, but this is not a terribly uncommon situation.
That's good.
Okay, thank you.
Yeah, thank you.
Thank you, Sandy.
Sure.
Madeline, do you want to unmute and ask your question? Here she goes. Okay. Hi, Madeline.
Sure. Hi. My mother, age 86, has MDS 5Q minus. She's been getting weekly blood transfusions since the fall. For the last several months, really, maybe longer, she has suffered from diarrhea and then constipation, all going on. The doctors don't think it's related to the MDS or even the transfusions. They think it might be irritable bowel, but they don't really want to do anything to check that. Maybe she's lactose intolerant now, so we're trying to go off of that. Have you got any thoughts on what could be causing this?
Right. So and she's not getting any MDS treatment per se, just transfusions.
She just went on a new treatment 3 months ago. She was doing, I'm going to forget all the names. She was doing 2 other treatments that didn't work, but she had been off of that since early January until 3 weeks.
And was that treatment a pill? Was that lenalidomide, Revlimid?
Revlimid.
Okay.
She was doing Revlimid.
Revlimid can cause diarrhea for sure. And in people who have, I don't know, how long was she taking it?
She took it from through the fall, basically.
Okay, so for a few months.
Yeah.
So it can cause diarrhea. It can aggravate underlying bowel problems. So if, let's say, you do have irritable bowel syndrome, there are several medications that can aggravate that. There are many other drugs that can cause diarrhea. Certainly lactose intolerant is a possibility. The best thing to do there is to experiment by leaving out lactose or using something like Lactaid, if you are eating dairy. There are, and then I don't know what her other treatments were. Transfusions generally do not cause diarrhea.
Thank you, Sandy. The next person is, excuse me if I'm not pronouncing your name correctly, Jagan has his hand raised.
Can't hear.
We must be having some difficulty with Jagan. I do have a question from Laura. For transfusion-dependent patients, how should one evaluate their ferritin levels? How active should one be in controlling levels? And what are the scores to look for? Is 2,500 a dangerous level?
So ferritin is reflects. It's a way that we try to estimate iron burden. It's not a perfect number because it can be reactive. So if you have a infection or something else going on, sometimes your ferritin can react to that. So we look at it really over time to really establish that trend. And depending on whose criteria you look at, as far as when is a ferritin likely to cause secondary organ damage, which is really the concern, that iron gets bound up in tissue. And in particular, it gets bound up in the liver. It can be bound into the heart muscle. So muscles in particular. It can really any tissue, but particularly the liver and the heart. And over time, that iron-laden tissue is inflamed, and then it can become irreversibly scarred because excess iron causes what we call oxygen-free radicals. These are inflammatory substances that can cause irreversible damage to tissue over time. So we monitor that over time, and so the range for where we are more concerned varies from anywhere from some guidelines saying 1,500 or more than 1,000, but certainly greater than 2,000 is where we begin to say the concern about tissue damage is more substantial.
Thank you, Sandy. I just want to say it's wonderful seeing everyone, and I recognize many of you. I just want to encourage everybody to, again, ask questions. Please raise the hand in the bottom menu bar if you have any questions, and then we'll call on you.
There's another question, Audrey, that's here that says, my physician is considering luspatercept and Retacrit and filgrastim, as Retacrit and filgrastim after a year are not showing distinct improvement in my low red blood cell counts. What can I share about luspatercept? So luspatercept is a drug that was recently approved in the US and has some approvals, I believe, in the UK, and I'm not sure about the rest of the world, but it works on what we call late phase erythropoiesis. So when you're making red blood cells, there are various stages, and at the very end here is where Procrit or erythropoietin epigen, I'm guessing that's what Retacrit is, works. Iron works in that same area there. Most MDS patients are not iron deficient, but it just helps basically those red blood cells finish that process of development. So it's allowing it to fully develop or differentiate. There are characteristics that you can acquire with MDS that block that last part of cell development. So that is basically how the drug works. It's given as an injection subcutaneously, generally every 3 weeks.
Thank you, Sandy. The next question comes from Michael. How can he get an effective referral when his insurance company won't approve doctors out of network, such as an MDS Center of Excellence like Mayo Clinic in Arizona?
Boy, if I could solve that problem, that would be fantastic, wouldn't it? Insurance issues are definitely a challenge. You can appeal for a one-time exception for a second opinion, but depending on your insurance plan, it may be very difficult to do that. I would say, contacting back to Audrey to find out what are the other options for MDS Centers of Excellence in whatever location you are, to see if there are some that might be in your network. And then, the other thing is to ask about, with whoever is seeing you currently, is there a way they can submit a referral that might be considered or approved by the insurance company? But that's a challenge for sure.
And I know in some cases, Sandy, when a patient's visit is not covered by insurance, sometimes it helps to ask your doctor to do a doctor-to-doctor consult.
Yep, and that's a very good point.
The next question comes from Laura. For transfusion-dependent patients, how should one evaluate? Oh, I'm sorry. I think I asked this question already,
Yes.
Forgive me. I'm going to go to the next question. Oh, I think Lori has her hand raised. Lori, please unmute.
Hi. I had a
Hi, Lori.
question. I'm new to the group. I don't know if you could hear me.
Sure.
Okay. I'm new to the group. I had to practically pull teeth to find out my gene mutation and an IPPS and all that from my doctor. Anyway, I found out my gene mutation is normal. My subtype is RAEB1, and my RIPSS is 4.5, intermediate risk. What does it basically mean? I mean, I don't know anything really about MDS that much.
So you're intermediate risk. So you're right in the middle. There's very low, intermediate, high, and very high.
Okay.
RAEB is refractory anemia and excess blast type 1. So it's based on the actual total blast count. The fact that you have no molecular or cytogenetic abnormalities is more favorable. Having a higher blast puts you is not in the low risk categories, but puts you in the middle and the intermediate. And so that helps us guide treatment decisions as far as, can we wait to treat you? Should we get you started on something sooner than later? Being in the middle, it means we're going to watch more closely and we're going to consider starting treatment sooner than later.
Okay. Because I'm getting a second referral second opinion really, because the doctor I went to really said that she was going to put it off because right now I'm doing dialysis as well.
Mm-hmm.
So she didn't want to do anything unless I insisted, and that would be chemo, she said.
Yeah, there are drugs that can be given during dialysis. Absolutely. So that's not a reason not to treat you.
Okay. All right. Because I really don't know that much about MDS yet.
Right. And so it's good
to second opinion.
And that's
so
great.
Find out.
Yep. And that is a great plan. And, and there are likely clinicians that are more comfortable treating someone who has more a rather, more complicated medical history, like you being on dialysis, but it doesn't mean you can't have your MDS treated. So that's great that you're going to get another opinion.
Should it be treated right now, or you're not sure?
It should be considered if you're intermediate, right? And I don't know the details of your disease, but that is something that you need to ask this other person that you're going to see. Is,
okay.
Right, how they're going to monitor you and when and what would make them consider treatment.
Okay, thank you very much.
You bet. Good luck.
Thank you.
The next question comes from Marcella. Their parent with MDS has multiple conditions, and they are concerned that there is not any shared communication between her specialists. How can I get that going on a regular basis?
So as I mentioned in the presentation, the first thing is to have a list of people. So we try very hard to ask people who all their ologists are, and make sure that we include that in our notes, where it says CC2 and who are we going to share information with. And that's the best way if you're, depending on the setting you're in, in our system, for instance, we have a medical record team that automatically then sends notes to whoever's in that list of providers. You can ask for a copy of your information to take to your other providers, just get all the cards together or keep it in a list and share it with everybody that you interact with, and so that they can try to work together as a team. It can be challenging, if they're not all in the same system, health network, if you will, but it's our responsibility to try to communicate, for instance, with your nephrologist for for our patient that just shared about dialysis, or a cardiologist or a diabetes specialist or whatever that is, so that we can make sure that we're doing the best thing for your overall health. But not all provider systems are effective in doing that. And so your tools are get on the patient portal for any provider that you're seeing who has one, so that you can access your own records, and then ask about getting copies so that you can take to your other folks yourself if it's not working otherwise. But the first step is just to let everybody know who's on your team.
Thank you, Sandy. Great answer. The next question is from Laura. She wants to know, can itching be a symptom of MDS or the result of transfusions? Can iron overload cause itching as well?
Yes, iron overload can cause itching. And we already talked about some of the rare subtypes of MDS. There are treatments for MDS that have some itching associated with them also. So depending on what treatment you're on, it might be a side effect of treatment. It can be a side effect of many drugs that are not necessarily for MDS, but that you might be taking for other reasons. So it's something, again, to talk to your team about, so that they can work through that process of what might be causing it.
Thank you, Sandy.
Sure.
Okay, I'm looking for hands raised. I don't see any at the moment. Again, if you're not comfortable asking your question on video, you can submit your question in the chat box. I don't want you leaving today with your questions unanswered. So please, ask your questions while we have Sandy available. Anyone?
Can I ask a question?
Sure. Oh, hi, Bernard. Sure.
So you explained before about the reasons why it's important for the provider to understand the IPSS score, but is the patient just walked out of leave? But is the patient? Would you do anything different depending on the score rather than worry more or less?
No, I mean, that's a really good point. I think it's really more about understanding. So the conversation we just had is to say, if I'm in an intermediate or high risk group and my people that I'm seeing right now are not offering me any MDS treatments, I might want to get a second opinion, right? And so you can find out about risk scores and treatments and, risk of leukemic transformation on the MDS Foundation website, but it's more about really advocating for yourself by understanding where you are on that continuum. And yes, it may cause more worry, but if I have very high risk MDS, my risk of leukemic transformation is much higher, and treatment should be started more promptly as a result of that. That's the standard of care. And so so it's really about advocating for yourself by understanding where you are on this continuum and what might be the best way to approach treatment.
Thank you.
Sure.
Thank you, Sandy. I see Karen has her hand raised. Karen, please unmute.
My question relates to the rash and itching again. How could I pursue receiving more information, or someone who might be curious about research being done on this situation, which seems to precede the counts dropping?
Right. So I think the big key here is to understand, first of all, is it directly associated with a change in the MDS? And it sounds like maybe that was part of what they were looking at. Having seen a dermatologist is perfect. They can, if they biopsy these sites, they may see an increase in certain types of cells that might then be able to be linked back to the MDS. But that's where you need the dermatologist and the MDS expert to collaborate.
And they kind of do what you do, like we've done the test.
And unfortunately, sometimes we don't have the answer. And then you just have to try to treat the symptoms. But if it's important, if you feel like this flares when the MDS is misbehaving, then just making sure that you're checking out both things and then acting on whatever information you gather as a result.
Okay, thank you. But there isn't any studies that you know?
No, not really. Now I'm itching now that we're talking about it.
Excellent.
Yeah. So no, not really, not for that.
All right.
And Sandy, what about an allergist? Only because I had itching.
Yeah, and that's a thought.
Allergist.
That's another way you could work through it. Sure, allergists sometimes will see you if they think it's some kind of an allergic reaction and work through what the offending item might be. They test for everything: certain plants, animals, foods. So they can do allergy testing. That's a good point, Audrey. Mm-hmm.
Thank you.
Okay, the next question comes from Madeline. What do you know about and I'm sorry if I'm not pronouncing it correctly, roxadustat from Fibrogen?
Is this in the chat?
It is. ROXA.
Roxadustat from Fibrogen.
Yes.
It is something that is just being studied in clinical trials. So I don't know whoever is it.
Fibrogen.
No, I'm looking. Madeline.
Yeah.
So I don't know if Madeline, if you're on a clinical trial or is that
my mother just got approved for compassionate use. She's in the third week of it.
Okay. So yeah, and so it's basically in phase 3 clinical trials. It's more for it's been studied more extensively in cardiovascular disease and for treating anemia and and so that's basically where it's been studied primarily. So they're trying to apply this for her MDS. Is that what you're saying?
Right, and as I understand,
For the anemia.
What it attempts to do is to persuade the bone marrow that it's actually at a higher altitude, so that it creates the red blood cells. And she has been below 8 on her hemoglobin, independent on weekly transfusions, as I said, since the fall. And she just got a score of 8.7 and didn't have to get a transfusion for the first time.
Oh, well, that's good. Yeah.
And I don't know but it's only been 3 weeks, and we were told it would be several months possibly before we saw results. And I just didn't know.
And some people respond more readily to these kinds of drugs than others. But that's great news for her.
We are very excited, but also worried about getting excited too. So, okay, thank you.
Sure.
Wishing her good luck with the drug. The next question comes from Marcella. Her mother is recently, is 96 years old with low risk sideroblastic MDS, CHF and has high blood pressure. Are the MDS specialists for this age group?
Say that one. Is that in the chat here?
It is. Her mother is 96. So
okay.
She's questioning whether,
low risk.
Is there ageism, I think, involved? Are the MDS specialists for this age group?
Sure. So age alone should never prevent treatment. So it would be more about how well controlled the other, congestive heart failure, high blood pressure, how well controlled those are, and is there a need to treat her MDS based again on that IPSSR score. So, people with sideroblastic low risk MDS who are not transfusion dependent might not need treatment right away. So it's really about, are there indications to treat? And if she's requiring transfusions, then that would be a trigger to start thinking about, the bone marrow not working as well and needing to do something about that. But age alone should not prevent treatment. And it's really about balancing risk and benefit.
Thank you, Sandy.
Sure.
Next question is from Laura. Are there some patients who should not be offered luspatercept if the drug is appropriate for their MDS subtype?
There are, risks and benefits to any treatment. So it's really about evaluating that. And then really the indications are very specific for a certain subtype of MDS. So this is, again, why you need to understand all of the attributes of your disease, not just IPSSR, but also underlying cell type. And so this drug is approved for a very specific subset. And so if you meet that criteria and are otherwise well, and even if you have comorbidities, if they're well controlled, then it would be something that you would try. And then as we do for any drug, when we start treating people, we're going to monitor you closely to say, are there any excessive side effects and that might mean that you're not tolerating that well.
Thank you, Sandy. Okay, I don't see hands raised again. I just want to encourage you to use this time. You know, you have Sandy here who's world renowned in the field of MDS. So I encourage you again to submit your questions. I don't want you leaving today without getting your questions answered. So please either chat us or raise your hand. Oh, I think I see a question coming in from Renee. Her MDS has transformed to AML. She was treated with 1 week of decitabine and 18 days of Venclexta. Now her neutrophils are not recuperating and are at 0.3 stagnant since April 10th. Can you talk about Neupogen, which her doctor wants her to use next?
So this is not at all uncommon with the combination of decitabine and venetoclax. And those cytopenias can last a really long time. The most important thing is whether or not you're experiencing infection. So you have to be particularly careful when your white blood cell count is that low. Generally what happens then is there'll be an adjustment in treatment. Using growth factors, so Neupogen in this case, that is a growth factor for neutrophils specifically, that has to be weighed with the risk of stimulating those leukemia cells. And so we sometimes will just monitor and hold off on reintroducing the venetoclax. And then sometimes we'll put you on what we call prophylactic antimicrobials or antibiotics, antiviral, antifungal drugs to help diminish the risk of infection. So it's really going to be up to your team to, again, balance the risks and benefits of all of those strategies.
Thank you, Sandy. I see Karen has her hand raised.
What are the symptoms of bleeding internally that you should become alarmed by? What does the patient feel, or how do you know?
Well, obviously, if there's blood in the urine, blood in the stool, bloody noses, right? That's an external manifestation. If you have more pronounced bruising, bleeding under the skin, but internal bleeding can be otherwise, you don't feel it, you get weaker, dizzier. If there's a very severe bleed, then some people, pass out, just because the blood volume is diminishing and your blood pressure is dropping as a result of that. So if you do ever see active bleeding, blood in the urine, blood in the stool, bloody noses, bleeding gums, things that you can actually witness, you need to make sure that you call your healthcare team and probably get your blood checked to see if the platelets are very low or hemoglobin's dropping substantially so that they can address that.
So it's not like a 911 call. It's a...
Well, if you pass out, it's a 911 call, but hopefully you want to catch it and get in and get your blood checked sooner before you get to that point.
Okay, thank you.
Yeah.
Thank you, Sandy. I see Yagan or Jagan, I'm sorry if I'm mispronouncing your name, has their hand raised. Are you there? If so, you'll need to unmute. Okay, in the meantime, we'll go to a question from Laura. She's curious about age-related bias when providing medical care to elderly patients. How can we better advocate for our elderly patients?
Yeah, and so that's an excellent question and something that we've been working on for years within the Mds Foundation, because again, age alone, chronological age alone should not determine treatment. decisions. And rather, we talk about physiologic age. So how fit are you? And we are actually just embarking on a Fit for Treatment campaign to really eliminate that disparity that exists in offering treatment to older patients. So the other thing that you can do is advocate for yourself, as we talked about earlier. So be informed, and then seek out an expert through again, getting in touch with Audrey and the MDS Foundation to help you find someone who would not discriminate based on age alone. Now, it's different if you're older and you have many other illnesses and they're not well controlled. And I'm not I always tell my patients, I'm not an expert in diabetes. I mean, I know enough, but I'm not the expert in congestive heart failure. So this is where you need to bring your team together to make sure that each one of those things is well controlled so that you are fit enough for treatment. So staying healthy includes managing comorbidities so that then people are going to consider you fit for treatment regardless of age.
Thank you, Sandy. I see Karen has her hand raised.
How does chemo and MDS affect an elderly patient's like 86 years old teeth problems? We have just been told that in order to get even a filling, you have to get a release from the oncologist and the cardiologist. Yeah. But today's dentists want a gigantic treatment plan too, and if you're going through chemo and all sorts of things, adding another preventative, or I don't know what they want to do, but tell me more.
Yeah, so that's a tricky one. If your blood counts are low, there's a risk of bleeding, obviously. It increases the risk of infection if your neutrophils are low. So in our patients who need extensive dental work, we ask about how important is that? Is it essential? Is that keeping you from eating? Is it increasing the risk of infection? For instance, if you have an abscess or an infected tooth, and then we have to co-manage. So we have people who do need extractions. And if their platelets are low, we're going to give them platelets right before they go over and see the dentist. So they literally come to us, get a platelet transfusion, and then go. We check that, what we call a post-platelet count. So see how well that platelet count came up. It's really up to the dentist to say, I need your platelets to be X or Y before I can do this procedure. We can then try to get you to that number. Sometimes that's not possible. And then in some patients who have low neutrophils, we would also prescribe an antibiotic before and after the procedure. And some of the dentists do that themselves. Usually it's a penicillin-like drug, like amoxicillin. So it depends on what they're asking. From cardiology's perspective, unless they have to use a sedative, or you've had a history of endocarditis or some other infectious etiology in the heart, it's usually not an issue.
Okay. Thank you.
Yeah.
That's just a new situation for us. My husband needed a filling. And then when we went, the dentist got all excited, and now we're waiting for.
Usually I always use the analogy if it's below the gum line or above the gum line, right? So if I need something below the gum line, like an extraction, a root canal, that's below the gum line. The risk of infection from that is greater. The risk of bleeding is greater. If it's above the gum line, I just need a filling. Then you're not in the tissue, the risk is much less. That's how I look at it.
Is it known that chemo affects or increases Does teeth decay?
No, transplants do, but generally not the drugs we use for MDS.
It's Vidasa.
Right, and it doesn't cause tooth decay.
Okay, thank you very much.
Yeah.
Thank you, Karen. Those are great questions. Okay. I don't see anyone else's hand raised. Again, we have about 10 minutes to go. In the meantime, I do have a question. Given the evolving shortages in blood products in many locations, is it reasonable to attempt to increase transfusion intervals and lower transfusion thresholds?
Right. So the current in the United States, there is what we call a restricted transfusion policy or approach, and that was generated out of data primarily for hospitalized patients, not patients with MDS. But our threshold for transfusion is generally 7, a hemoglobin of 7 in the United States, and or higher than that if you have comorbidities that are primarily heart and lung associated, where you aren't going to tolerate that level of anemia as well. So we look at the whole picture. And then you always have to understand that transfusions they're borrowed blood, right? They're not your own, they're borrowed. They only last a certain amount of time, and they do carry risks. And so we try to weigh that risk of infectious complications that can come with transfusions, getting antibodies over time, so that then it's harder and harder to find blood to match, and also the iron overload. So we're balancing all of those things with your symptoms and other risks for having a low hemoglobin. So there isn't one number that is universal. It's really understanding the risk of transfusion, understanding your underlying comorbidities, and your symptoms collectively.
Great answer. Thank you, Sandy. Karen, I see you have your hand raised. Please unmute.
Oh, hi. There are a lot of Karens on here. My question has to do with diet and MDS.
Yeah.
So I'm overweight and kind of have always struggled with my weight, and I would like to lose weight, but I was wondering what the best diet, weight loss diet or overall diet is for somebody with MDS.
There aren't any specific dietary restrictions or other direct contraindications. As I mentioned earlier, we try to avoid people going to extremes just because that's not good for most people's bodies. But I would just say, first you need to also look at, are there other things associated with weight, high blood pressure, high lipids, diabetes, thyroid dysfunction. There are many things that can affect weight gain that should be managed optimally that might then help with weight loss. But it just basically gets down to diet and exercise, which, it's easier said than done. I think, we talk about the COVID-19 being the 19 pounds everybody gained during COVID, just from being inactive and being cooped up and not eating normally. But I think getting out and getting active, talking to your team about, if there are other strategies or medications or treatments or very specific weight loss diets that are safe for you to do with whatever else you have going on. So it's something that you should chat about with your team to get some guidance on that, and ask to see a nutritionist so they can help you work through what might work for you.
Okay, thank you.
Sure.
The next question comes from Marcella. She just received a ferritin level of 2,513 and has low risk MDS, sideroblastic MDS, and is transfusion dependent, plus has erythropoiesis agents, what would be the next steps?
So the what we call iron chelation medications, so drugs that you take to bind iron and get it out of your system. The only way you can get rid of that iron is to bleed. So if people have good hemoglobins, we can phlebotomize them, take blood off, and then iron is bound to red blood cells, right? But most MDS patients who are transfusion dependent don't have that option. So iron chelation drugs can be used. They take time to work, sometimes more than 2 years, and they have their own set of side effects. So we, again, try to balance out what's the risk of the iron overload, what is the risk category of the MDS, and in lower risk, we consider that iron chelation therapy. And then, what are the side effects of the iron chelation treatment? And is that something that might be a problem for you? So those are the things I would ask about with your team, your healthcare team.
Hi, everybody. I think we have about 4 minutes left. Anyone else want to raise their hand to ask a question? I think we have time for one more question. Sandy, this is one from someone who had a bone marrow transplant last year, doing relatively well with mild graft versus host disease. She wants to know if the J&J single vaccine or the first dose of the Pfizer vaccine is more effective for a post-transplant patient. She's been told some transplant patients experienced a graft versus host flare-up or reactivation of their graft versus host disease after receiving their second dose.
So the COVID vaccine is basically need your immune system to react to produce the antibodies, right? It's so that you have some level of immunity to COVID-19. And so much like many of our autoimmune patients, people that have autoimmune disorders or autoimmune hemolytic anemia or many other situations, that flare in the immune system can sometimes, that we need to happen to make antibodies to the virus, can make a flare in these other processes that you have going on. And graft versus host is, in a sense, the immune system in your body doing this dance over time. And so generally that will quiet down over time. And, you may just need to have a short-term burst in GVH management, but sometimes we just watch it if it's not severe, and it could correct back all by itself with time. So there's no recommendation for one vaccine or the other. They all need the immune system to activate to produce antibody. That we all need that to happen to have some level of immunity against COVID-19. But it's about monitoring the severity of that flare, if you will, and deciding whether it needs treatment or just monitoring.
Thank you, Sandy. Okay, we have time for one last question. Laura wants to know, can X-Jade cause side effects such as diarrhea? And how is the best way for this to be managed? And the second part of her question is, are generic drugs equivalent to the brand name?
So yes, X-Jade can cause GI side effects, including diarrhea. Best way to manage that, people sort of strategize about what time of day to take it. So if I have a flare and, I'm sometimes taking it before bedtime is more effective. Deciding about, can it be taken with or without food, whatever the drug is that you're taking can make a difference. Making sure you're getting adequate hydration, talking to your team about what kind of diarrhea medications are safe for you to use. And there's great quick tips and the building blocks of hope. So I refer you back to that. As far as generics, the new thing being biosimilars are, approved based on having similar chemical attributes to what we call the reference drug or the brand name drug. So a biosimilar, by definition, has met criteria for their biosimilar. They're the same. They should act in the same way. Generics are a different category in that they're saying I'm just going to make this same compound using that sort of recipe, if you will. And generally, they are touting that they're less expensive. We've had patients switch to generics by their insurance company without us knowing. And there are people who have side effects on one brand and not the other. So if you've been switched to a generic for whatever it is, and you notice a change in your symptoms, report that, and then it's up to your healthcare team to, advocate for the brand name if there's documentation that you did not tolerate the generic or the biosimilar.
So thank you, everyone. That's all the time that we have for questions. Thank you, Sandy, for your wonderful presentation and your time and effort that went into preparing for this webinar. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with a link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.
Thank you, everyone. Good luck to all of you.